All right, just a little more housekeeping to do. As you all know, I hope, that we want to be able to answer all your questions. And to do so, just remember to go to the left side of your device. You'll see a little people icon there. It's the top one. Click on that, and then you'll have a window open on the right side of your device. And that's at the bottom there. You'll be able to submit your questions, your thoughts, your opinions, whatever you may like to set in. And we look forward to it, and we hope we're able to answer your questions. If not today, certainly after the conference, which ends on Saturday. Sometime next week, probably, if we can't get to all of them. Also, a reminder, be sure to stop by our exhibit booth. And please know that all the sessions, if you haven't been able to sit in on one that you really had some interest in, by all means, they will be available on demand. So also, we have a tie. Where is that tie? Oh, here it is. Here's this tie. This is the Hope tie. If you haven't had a chance to put a bid on this, for those who were part of our opening session yesterday, you saw that this tie represents the gold that we have in our logo. The hope for a disease-modifying treatment coming as soon as possible to our community. So if you'd like to place a bid on the Hope tie, please do so by going to joel@ataxia.org, and we'll identify the winner on Saturday after the conference. All right, our next session is entitled Standards of Clinical Care for Those Living with Ataxia. Our presenter is Dr. Theresa Zesiewicz. Dr. Zesiewicz is a professor of neurology and research at the University of South Florida in Tampa. Dr. Zesiewicz has a very busy practice, seeing more than 2,000 patients with movement disorders on an annual basis. Let's head on down to Tampa. Dr. Zesiewicz.
Hi, everyone. I'm Dr. Theresa Zesiewicz, and I'm from University of South Florida. And welcome to the National Ataxia Foundation meeting. It'll be great to see you all in person at some time soon, hopefully. Today, we're going to be talking about standards of clinical care in ataxia. So ataxia and cerebellar syndromes. Ataxia refers to a staggering gait. So this is when you're walking with your feet wide apart and you have balance dysfunction. And the cerebellum is the part of the brain that's responsible for balance and coordination. But with cerebellar syndromes, you not only have ataxia, you also have tremor, slurred speech, swallowing problems, dizziness. You may notice eye issues and even double vision. Well, understanding cerebellar diseases and finding an eventual treatment and a cure is the goal for all of us. Next slide. So today we'll be talking about standards of clinical care. So ataxia is a neurologic symptom that's present in many diseases and conditions, but the causes of ataxia are vast and the workup can be very complex. These diseases are relatively rare and clinical care for ataxia patients may vary widely. Unfortunately, there are few doctors who truly specialize in ataxia and cerebellar syndromes around the country. I also have patients who come to me and say that a healthcare provider said, "You are the first person I've ever seen with a spinal cerebellar ataxia or Friedreich's ataxia," just because they're rare conditions. So the standards of clinical care should be defined because clinical care for you can be challenging. Next slide. I just want to spend a few slides talking about from the time you come to the clinic to the time that we want to decide on possible treatment for you. So the standard of clinical care starts with history. We're always going to ask you about when the ataxia symptoms began. Did they start quickly, suddenly, as they would with a stroke? Or did they start slowly and then progress, as you would see with a degenerative disease or a more genetically inherited ataxia? We're going to ask you questions about your family history. What about mom and dad? Were mom and dad in a wheelchair or a walker? How about your siblings? We're going to ask about whether your ataxia was progressive or non-progressive. Did you have a stroke and that's what caused the ataxia and it doesn't progress? Or do you have a degenerative ataxia which has progressed over time? What's the age of onset? Is the ataxia present in a child, in an adult, or even in a baby? We'll look at other neurological and medical symptoms, your medications, some of which can cause ataxia as a side effect, your past medical history, social history like smoking or drinking, and a review of symptoms. So how many times have you fallen in a month? Do you have swallowing problems, urination issues, bowel issues, depression, anxiety, or speech issues? Next slide. So the standard for clinical care begins with a neurological exam, and we'll do that the first time we see you, and we'll do that at all subsequent visits. We're going to look at the way you walk. You know, it's very important in movement disorders. We always have a joke amongst us movement disorder physicians that we need to accurately identify the movement disorder, because if you can't identify the movement disorder, you can't go on to treat it. But some people come into the office with problems walking because they have spinal stenosis or a hip problem or a foot problem. It's not necessarily ataxia. So we want to make sure that you are definitely suffering from ataxia and that you have a cerebellar syndrome. You may have a sensory syndrome as well. We're going to ask you to perform other tasks like finger to nose, for example, or finger chase or rapid alternating movements. And then we'll look at other things like your strength, your sensation, and your reflexes. And that's just standard of care, and we'll do that every time. Next slide. We may even ask you to take part in a clinical rating scale. Clinical rating scales are scales that look at different symptoms of ataxia, and that we test you on those, such as the finger to nose or finger to finger, rapid alternating movements, your walking, how you stand, and how you speak. And they are associated with a number. And at the end, we can give a number to the scale. So you have a total. The one that we use a lot is the SARA, which is the scale for assessment and rating of ataxia. There are others like the ICARS. But the reason we do it is that it's a quantitative or a semi-quantitative measure of how you're doing. So that each time we see you, we can look and measure your progression. So either you're getting better or worse, and we can do this with a numerical system. Next slide. If you have new onset ataxia, you probably will warrant an MRI or a CAT scan. We're looking for structural or vascular lesions, brain tumor, ischemia, a stroke, multiple sclerosis. And that's if you've got new onset ataxia, or if we've never seen you before and we don't have an MRI with you or a CAT scan. There are also some things on the MRI that may point us to what type of ataxia you have, such as multiple system atrophy, which has a hot cross-bun sign, or spinocerebellar ataxia or degeneration, which shows atrophy in the cerebellum. Next slide. So standard clinical care and diagnosis comes down to a formula, although medicine is always an art. But there is a way for us, after we talk to you and examine you, to try to put things together to see what we think you have and what type of ataxia and etiology you're suffering from. We're going to always ask you about the history of your illness, your family history, look at your current age, what age of onset you had when you had your cerebellar symptoms and ataxia, whether the ataxia was progressive or non-progressive, the timing of ataxia, was it acute or was it chronic, and other comorbid conditions. So let's look at a few examples and put our formula in place and see what we come up with. So a 12-year-old boy having balance issues in the schoolyard for a few years since age 8, no family history, slowly progressive. No family history, current age is 12, age of onset was 8 years, it's progressive. It started slowly and got worse. This is a patient that you would think about with Friedreich's ataxia, which is one of the most common ataxias in the world, and especially occurs in younger patients, those who are pre-adolescent or teenagers, and it's autosomal recessive. Let's look at the next example. A 40-year-old woman with a 5-year history of progressive imbalance, and mom had a similar disease. She's 40. She has a family history. She had this at 35. It's slowly progressive, and it started slowly and became chronic. This is a person you would think about a degenerative condition or perhaps even a genetic ataxia. At least it puts us in the ballpark. Next slide, please. A 56-year-old man with new onset ataxia for a few weeks. He suffered from severe case of herpes zoster, not progressive, no family history. Okay, man is 56. This happened suddenly. It hasn't progressed. He had a severe case of zoster. Doesn't say it, but he also had a headache. This could be an encephalitis where the person has a cerebellitis or an inflammation of the cerebellum. Next one, 70-year-old woman with ataxia, dizziness, and Parkinson's for 3 years, progressive, no family history. No family history. She's mildly elderly. She's 70. This began 3 years ago. It began slowly. It is progressive. She has Parkinsonism. You would think about something like multiple system atrophy in a person like this. Finally, 75-year-old man with ataxia, action, postural, and rest tremor, progressive, and a grandson with Fragile X. This man is 75. He has a slow progressive disease, but he has a lot of tremor. And he also has a grandson with Fragile X. You would think about Fragile X tremor-associated syndrome. These are indefinite diagnoses, but there's a way for us to tell what you have or what you might have by just the history and the neurological examination. Next slide. Okay, so now let's get on to standard of care for treatment. There are no federally approved drugs currently that can cure or treat genetic or degenerative ataxias yet, like cerebellar ataxia, spinal cerebellar ataxia, or to slow the disease progression. But we have great news. And the great news is that the future treatment of these ataxias is a priority, not only to research groups like the great NAF and other pharmaceutical companies, but for all of us. Even gene therapy and other options are on the horizon for many of these ataxias, including Friedreich's ataxia and being discussed for spinal cerebellar ataxia. I'm sure Dr. Perlman has talked about in her great lecture, the pipeline of future treatments. So we have come light years in the past 10 years towards turning our attention towards a treatment and a cure for these diseases that are marked by ataxia. In short, the treatable ataxias are those that are acquired. They are due to another reason. So ataxias that are due to vitamin deficiencies or a metabolic disturbance, medication side effect, autoimmune disease where your body reacts against itself, or even infection. Next slide. It seems like a busy slide, but these are immune-mediated ataxias. These can be treatable. When a certain factor triggers an immune response, you want to eliminate the antigen. For example, someone who is allergic to gluten and has a gluten-associated ataxia. The way to treat this is to eliminate the gluten. Another example would be someone who has a tumor and has an ataxia secondary to what we call paraneoplastic syndrome. We want to excise the tumor. And there are others too, stiff person syndrome, for example. So not only do we want to deal with that which caused the ataxia, but sometimes we also want to treat patients with immunotherapy, like perhaps steroid or intravenous immunoglobulin, some of those. So the treatment is introduced at an earlier stage, the earlier the better, when the cerebellar atrophy is still mild. So these are the immune-mediated ataxias. Next slide. Then we have the genetically inherited ataxias, spinal cerebellar ataxias in all the forms, Friedreich's ataxia. Most of the spinal cerebellar ataxias are autosomal dominant, Friedreich's is autosomal recessive, et cetera. And there are others, mitochondrial ataxias. Clinical trials are currently ongoing, even if they're close to enrollment right now, but we're awaiting study results on not only spinal cerebellar ataxias, but also Friedreich's ataxia. And there is a vast clinical pipeline for many of these research studies that are ongoing. Off-label medications for these diseases are tricky. One of the problems with them is that you can have a very high placebo rate. You need hundreds and hundreds of patients in a clinical trial to have the statistical power to tell if the drug is beneficial. If it's given to 1 or 2 people, there may be a placebo effect, and we really don't know if this drug is going to be efficacious or beneficial. The other thing is that when we give a patient a drug and we want to test the patient, suppose you want to come in and receive one of these drugs for ataxia, we can't really test you or take data on you unless we have an IRB institutional review board reviews what we're doing and a consent. Okay, so off-label medications are tricky. I used to be much more likely to give patients off-label medication and get an IRB and go through all the process. But now that there is a pipeline, we have pharmaceutical partners, these are rare diseases, it's very important that we all work together towards larger clinical trials where we have the power and we can tell if these medications are efficacious. So I could urge you to continue to partner with your ataxia expert, your primary care physician who can talk to an ataxia expert, and to be apprised of any of the clinical trials available. Ataxia and Parkinsonism is usually a disease called multiple system atrophy, either P for Parkinson's or C for cerebellar. And this is where a person has slowness and stiffness and imbalance, symptoms of Parkinson's, and on top of it, they also have ataxia and cerebellar symptoms. Added to this is what we call dysautonomia. This is the involuntary nervous system which controls blood pressure and urinary issues and bowel problems, etc. So patients may try a Parkinson's disease drug with multiple system atrophy, but they're probably not going to get much benefit from it. What is important is that we deal with the symptoms of the dysautonomia. So if a multiple system atrophy patient has a drop in blood pressure, we want to make sure that we're dealing with those drops, because if we don't, the patient can faint and can fall down. Urinary symptoms in these patients can be really, really tough, as well as bowel syndrome and symptoms. So we try to deal with the symptoms surrounding the multiple system atrophy. Next slide. So standard of care in the ataxia does include treating the symptoms surrounding the ataxia, even if we can't cure the disease itself. And the symptoms include spasticity, which many spinocerebellar ataxia patients have with physiotherapy, medications, or Botox. Tremor, which may be treated with medications, even in some cases with surgery. Dystonia, which is an involuntary muscle contraction. Often we can treat that with some medication and botulinum toxin. Scoliosis and Friedreich's ataxia. Pain. There's no reason in this day and age that you should be in terrible pain. So I urge you to talk to your primary care and your neurologist if you do have pain. Cardiac disease or palpitations. We see this mainly with the Friedreich's ataxia patients who do have cardiomyopathy and hypertrophy as part of the disease process. We want to be able to treat your bladder dysfunction, especially if you have urinary tract infections, if you're having overt or too much urinary incontinence, which is very important. Next slide. Swallowing and dysphagia are big problems. If you have difficulty with swallowing, we'll do a swallow study, get you to a speech and language therapist. Sialorrhea or excessive salivation, also very important. We want to get you to speech or language therapist. Bowel dysfunction. And with ataxia, there are a lot of falls, and we want to treat injuries and fractures. Next slide. Eye issues. You may need to see an ophthalmologist, perhaps even for a prism or to get an evaluation. Cognitive issues. Patients who are not thinking the way they used to. They're having memory problems. We may need to examine you formally for that. Depression and psychiatric symptoms, very common in the spinocerebellar ataxias and in other neurodegenerative diseases. It's very important that you talk to your physician if you're having any depression or anxiety, because we need to treat that. We may send you for counseling. You may need some medication. It's just very common, nothing to be embarrassed about. We've heard it all, and it's important for you to talk to us about that. And also sexual dysfunction. Well, we urge you to talk to us about any of those issues. Next slide. So in 2018, a group of us published a systemic review of the treatment of cerebellar motor dysfunction and ataxia in the journal Neurology. And this was published in accordance with the American Academy of Neurology, where we looked at all the studies for clinical care and treatments for the past 30 to 40 years. Next slide. There were a few recommendations for patients with episodic ataxia, so ataxia that occurs quickly and goes away and can occur several times a day. Those patients can take a drug called 4-aminopyridine. In Japan, there is a lot of research going on with a drug called thyrotropin releasing hormone that possibly may help some ataxias. There are some studies that show that it may not, and I think that the important thing here is that research is ongoing. And maybe one of the most important medications was riluzole. This is a neuroprotective drug that's used to treat amyotrophic lateral sclerosis, or ALS, better known as Lou Gehrig's disease. And for patients with several types of ataxia, riluzole did improve ataxia at least 8 weeks and sometimes for longer. And this was conducted by research in Italy by Ristori et al. There is ongoing research concerning riluzole right now. And I think the study is close to enrollment, but it is ongoing and it's a long-term study, and we're waiting for the results to see if riluzole can have some symptomatic or even neuroprotective benefit in ataxia, specifically spinocerebellar ataxia. Next slide. There are other meds that were studied in small trials. One of them was varenicline, one of them was buspirone, amantadine, and lithium. Again, the problem was that these were relatively small trials. The effect could be quite small or equivocal, and there's always a concern about a placebo effect. So larger studies would be needed before recommending these. And then it's just very important for all of you to keep, normal health, just health like everyone else would have. So keep a normal BMI. You have to take care of comorbid conditions like diabetes and high blood pressure, heart disease, lung status, keeping your cholesterol down, stroke prevention. Those are just things that all of us need to do, especially when we get a bit older. If you're smoking, important to try to stop smoking. If you're drinking, important to cut back on alcohol. We would say that to anyone. That's just standard of care. Next slide. Patients also ask us about vitamins and supplements like coenzyme Q10. They ask if this is beneficial for health, including cardiovascular system. CoQ10 is a component of the electron transport system, and it acts as an antioxidant. And it's long been studied in many neurodegenerative diseases like Friedreich's ataxia and Parkinson's disease, where it hasn't been shown to be especially beneficial in either. However, there are some ataxias, next slide, one in particular, which is a rare ataxia called autosomal recessive cerebellar ataxia type 2, that is due to mutations of a gene that's involved in the synthesis of coenzyme Q10. And coenzyme Q10 may have some benefits in that particular type of ataxia. I would say you should speak to your primary care physician, talk to him about cardiac health, and see if vitamins and CoQ10 would be helpful for you. There are ataxias that are due to deficiency of vitamin B12, so it's important to get vitamin B12 tested. Also, vitamin B1 is important. So vitamins and CoQ10 can be beneficial. I would talk to your primary care or your neurologist about that. Maybe they can shed a little bit more light on whether these are supplements and vitamins that you should be taking, as anyone would take. Next slide. Physical therapy is extremely important. Home exercise programs, stretching, core strengthening is so important with ataxia. Balance, cardio, occupational therapy, weighted vests, orthotics, driving evaluations, all of these kind of physiotherapy activities are very, very important. And in a time like this with the COVID-19, it's very difficult because you probably have not been able to do as much physical therapy as you would have wanted. You can't get out to go to your physical therapist 3 times a week. It may be hard to bring someone in. And we are concerned about patients with ataxia who haven't been able to keep up with physical therapy and physiotherapy. It's very important to keep up with it to the best of your ability. Physical therapy has been shown to improve neurologic status significantly when it's done intensively, but it has to be done safely. I have patients who come to the clinic and say, this coronavirus has been going on for a year and I haven't done much. What should I do? It's hard to go into physical therapy 0 to 60 miles an hour if you haven't done anything. Important thing would be to try to get up and walk every hour. If you haven't done anything in months, maybe even a year, try to get yourself up every hour, but do it safely. And then every day, increase that by a few minutes. So maybe you just need 5 minutes around the house every hour. By next month, make it 10 and keep moving, because when this ends, we do need to get you back to physical therapy and to physiatry. It's very, very important for you. The National Ataxia Foundation does have a drug development collaborative. Pharmaceutical industry consortiums have the principal goal of accelerating the development of treatments for ataxia. And as I said, we have come light years in the past 10 years, and the National Ataxia Foundation is leading the way towards drug development collaborative, and we all need to work together. These are rare diseases, and we need to work together to find a treatment and a cure. Next slide, please. National Ataxia Foundation also funded a clinical research consortium for spinocerebellar ataxia. This is a natural history study that collects data that shows how a specific disease progresses in individuals over time. This is open. We recommend that your ataxia experts and continue to do this with your participation, your kind participation. It's very important to see how a disease progresses over time, and only you can give us that information. So thank you for that. Next slide. So in conclusion, standard of care for all ataxias are to treat the associated symptoms of ataxia: spasticity, tremor, dystonia, pain, bladder dysfunction, bowel issues, depression, anxiety, swallowing problems, and speech issues. For Friedreich's ataxia, there is special attention that needs to be paid to cardiac issues, diabetes, and scoliosis, like getting an EKG or an electrocardiogram, spine series, and diabetes screen. For immune-mediated ataxias or for autoimmune ataxias, we want to remove the trigger, that which is causing the ataxia, and consider medication such as immunosuppressant. For spinocerebellar ataxia, clinical trials are ongoing. We'd recommend that you talk to your ataxia specialist, continue to go to your doctor visits, even if they're by telehealth. Eventually, they will be back in person. We want to follow you and monitor your progress. For ataxia and Parkinsonism, we may treat the symptoms of dysautonomia like low blood pressure. Levodopa may be tried, but can lead to low blood pressure and dizziness. I want to thank you for meeting with me today. Thank you for inviting me. It's been an honor to be a speaker at the National Ataxia Foundation meeting. Thank you for your participation in the trials and for all you do for us. We hope to see you in person soon. Thank you.